Good morning. I want to thank the organizers for the invitation to speak during this very inspiring conference, and especially Geert of HID. My name is Goকথn, and I'm an assistant professor in health law at Ghent University, and I'm a part of the research group META-MEDICA. And META-MEDICA is a very young research group that focuses on research and education regarding the ethical and legal frameworks of digital and technological innovations in healthcare. And together with my colleagues, Heidi Mertes, medical ethics, and Masa Shabani, health privacy law, and our PhD students such as Sofia Palmieri, who perhaps you've already seen in action during this conference, it's our goal to provide integrated ethical legal answers to many questions that raise with regard to the digital and technological innovations in healthcare. Perhaps you think, oh no, such an early hour and a legal presentation and health data that will be about GDPR. But I have to surprise or perhaps disappoint you. I will not be talking about the GDPR. I will be talking about the other elephant in the room, being quality, or more specifically, quality of care. In the next 20 minutes, I will explore with you the dynamic complexity of the question of quality of data from a broader perspective, being quality of care. It's my perception that guaranteeing the quality of health data means that you necessarily have to take into account the bigger picture of quality of care, with a special focus on patient-centered or person-centered healthcare. This getting to know really what quality of care is all about. So therefore, the concrete question that I want to tackle in my presentation, therefore, will be, what comes first? Quality of care or quality of health data? And is quality of health data a precondition in order to be able to speak about quality of care, or is it the opposite around? In order to be able to answer this question, I will firstly explore with you briefly what the concept of quality of care is all about, in all its complexity on its own. And in my second part of my presentation, I will then try to answer this chicken or egg question. So let me first start with quality of care. And although since the 80s, there have been a couple of initiatives with regards to the concept of quality of care, perhaps it comes to a surprise to you, but quality of care as a policy, as a regulatory concept, is relatively young. If we take, for example, the initiatives taken by the Council of Europe in the late 90s, for example, the European Convention on Human Rights and Biomedicine of 1997, which stipulates for the first time the minimal values, minimum rules that need to be taken into account when creating a health system, we don't see quality of care in it. The only mention of quality of care can be found in Article 3, that describes the right of a citizen to equitable access to healthcare. And equitable access to healthcare there is described as care of an appropriate quality, but what quality is not defined. And indirectly, the convention also mentions quality when it sets the rules for professional standards, stating that this must be carried out in accordance with relevant professional obligations and patient standards. However, if we really look at the explanatory report of this convention, which describes in detail what this convention is really about, we don't see quality of care nowhere. So it only was in the late 90s, beginning 90s, that things started to change. And it started to change since the Institute of Medicine of the US published two very important reports with regard to quality of care. The first one was To Err is Human, Building a Safer Health System of 1992. And in this document, the Institute of Medicine mentioned that there were a lot of preventable medical errors, 44,000 to 98,000. Preventable deaths each year with an associated cost of between $17 to $19 billion in the US. And the goal of this document was not to point the finger to the physicians who made the errors, but to point the finger to the health system. And therefore, this document was used as a setting of the agenda for reducing medical errors and improving patient safety on the level of the patient-physician relationship through a design of a safer health system. The second document, only 2 years after the Human, is the document Crossing the Quality Chasm. And this document, once again, the Institute of Medicine mentioned a couple of very interesting things, such as healthcare harms patients too frequently and routinely fails to deliver its potential benefits. Indeed, the document mentions between the healthcare that we now have and the healthcare that we could have lays not just a gap, but a chasm. Quality problems occur typically not because of the failure of goodwill, knowledge, effort, and resources devoted to healthcare, but because of fundamental shortcomings in the ways care is organized. It is within the scope of this report that the Institute of Medicine also created the so-called 6 dimensions of quality of care. They provided overarching principles for specific directions for policymakers, healthcare leaders, regulators, clinicians, and so on. They've become a list of performance characteristics that, if addressed and improved, would lead to a better achievement of healthcare. And these are the 6. Of course, patient-centered healthcare, meaning care that is respectful and or responsive to each patient's preference, needs, and values. Second, to avoid harm to patients from care intended to help them. Third, timely reducing waits and sometimes harmful delays to those who receive and give care. Then there's equitable care, which means to provide care that does not vary in quality because of gender, ethnicity, geography, or socioeconomic status. We have effective care, meaning to provide service based on scientific knowledge to those and only those who can benefit from the intervention. And then we have the 6th one, efficient, which means to avoid waste of equipment, energy, supplies, and IDs. But what we see in practice is that over the years, these 6 quality aims have developed, have evolved into quality dimensions as a guidance for making strategic choices in health systems. And the reason for this is the following. Traditionally, the main focus in quality of care was put on the macro level, emphasizing the importance of patient safety in the patient-physician relationship. In line with this focus was a growing recognition of the concept of patient autonomy and the right to self-determination, with a clear recognition of patient rights as one of the cornerstones of a patient-centered healthcare system and a trustworthy healthcare system. The meso as well as the macro level received less attention. Nevertheless, over the years, there has been a shift from a sole focus on this patient-physician relationship towards a focus on creating a qualitative and patient or person-centered healthcare system as a whole. And in this person-centered healthcare system, we do not look only at the quality of care in this patient-physician relationship, we also look at conditions that guarantee quality of care within a broader healthcare market, such as quality of care of healthcare institutions, quality of care of medical devices, medical equipment, etc. It also includes the condition on even higher level, meaning conditions in order to create a qualitative healthcare decision-making process on the level of policymakers. How do we make sure that every healthcare player is taken into account and good health policy can be created? The shift from a sole focus on quality of care on a patient safety level towards this 3-level approach can also be seen in the way that healthcare policies with regard to quality strategies were organized. It was within this evolution that the Institute for Healthcare Improvement of the US developed in 2007 the triple aim for value-based high-level quality care. The first step in this perspective was the evolution from a sole focus on patient safety towards a focus on a value-based healthcare as an important strategy to ensure high-quality healthcare with simultaneous cost efficiency. The Institute for Healthcare Improvement therefore stipulated that within this triple aim, a healthcare system should strive to, in the first place, improve the patient experiences, respecting the patient values, wishes, etc., but also to improve the health of populations in general, as well as to reduce the cost of healthcare per capita. So by combining these three, this institute really believed that we could improve the quality of healthcare systems in general. But becoming aware of the fact that creating a value-based healthcare system solely on the improvement of the position of the patient and population's health is not enough, the Institute added a fourth aim for achieving a value-based high-quality healthcare: the well-being of the clinicians and the healthcare personnel. It mainly focuses on how to improve the situation of healthcare providers, since happy helpers make better care. Within this aim, also a better use of, for example, electronic health records can be taken into account, including clinical decision support systems. Today, this concept has evolved even further, and we added a fifth aim. We're now at a quintuple aim, which incorporates health equity as another key element necessary to truly achieving improved patient care outcomes and costs. Without really understanding the social determinants of health, which drives of 70% of the healthcare outcomes, and without a clear path forward to solve the problem of health equity, a lot of attempts to achieve a value-based quality healthcare will be futile. And parallel to this evolution of the triple aim into a quintuple aim, also the ways of looking at the 6 dimensions of quality of care has evolved. In 2019, the European Observatory on Health Systems and Policies and the OECD launched the report Improving Healthcare Quality in Europe. In this report, the European Observatory has developed a conceptual framework to address quality improvement through quality strategies. The reason for this was that over the years, these 6 dimensions of quality of care have developed. Some of them were replaced by more suitable dimensions, others were added. But this created a very long and inconsistent list of different dimensions, inevitably contributing to a confusion of what the concept of quality of care is really about. So to bridge this gap and to facilitate a better understanding of characteristics of quality strategies and of how they can contribute to a better quality of care system, a comprehensive system of 5 lenses was developed. And these are the 5 lenses. First of all, the 3 core dimensions of quality, being safety, effectiveness, and patient-centeredness. Second, the 4 functions of healthcare: primary prevention, acute care, chronic care, and palliative care. Third, 3 main activities of quality strategies. What do we want with these quality strategies? Do we want to set standards? Do we want to monitor? Or do we want to assure improvements? Fourth, the so-called obedience triads. Do we focus on structure when it comes to quality of care, on processes, or rather on outcomes? And fifth, the 5 main targets of quality of strategy. For who are we doing this? To improve the quality of care for the health professionals, for health technologies, for providers of organizations, for payers, or for the most important group, the patients. This framework really facilitates a better grasp of the key characteristics of individual quality strategies and guides the discussion about their potential contribution to high quality care. So the main message of this very interesting report is that if you want to improve quality of care, you really need to know what the broad context is in which you want to make this quality improvement happen. Taking into account not only the specific intervention that you want to tackle, but also the level of care delivered, the persons and institutions involved, the reason for quality improvement, etc., etc. Or in other words, when it comes to quality of care, there's no one-size-fits-all story. And with the digital technology kicking in healthcare over the last years, we were initially blurred a bit by the feeling that we were walking on clouds. When talking about digital and technological innovations in healthcare, the sky seemed to be the limit. The healthcare world as we know it stopped turning for a moment. And also on a level of quality of care, questions such as, will robots, AI, and other technologies replace physicians and deliver an even higher level of quality of care, were being asked. Every new technology was presented as the best tool, making healthcare so much better, more accurate, more precise, more qualitative. Technological and digital innovations in healthcare seem to take part over the central place in our healthcare systems. But of course, academics don't like to walk on clouds. We prefer solid ground underneath our feet. So it didn't take very long before we started posing questions with regard to this new wave of healthcare. Questions such as, do we have to create a total new healthcare system? And therefore also a new quality framework based on these new technological innovations, including, for example, also a new framework for quality of health data? Will the patient remain indeed the central person in this new system, or will the main focus just be on technology and data? And is the patient perhaps only just a client who happens to be a very interesting collection of health data? And what with the enormous lack when it comes to digital health literacy? Will my grandmother, who only has a very old mobile phone and still does not know what a medical app is on her smartphone, still be able to enjoy a qualitative healthcare system? It seems that we have to start over and rebuild the entire framework for a digital qualitative healthcare. But the question is it the correct approach? And in my opinion, the answer is no. It's not that innovation will take over. We're not living on a digital healthcare cloud. The question is, how can we use these technological and digital innovations in order to create an even better person-centered healthcare system? And this on the three levels: micro, meso, and macro. So we're basically just taking the next step. And one of the main goals for patient-centered healthcare systems is in making it possible that citizens, and in particular patients and healthcare professionals and society as a whole, will trust the system. And this will be one of the main challenges for digital health as well. We have to guarantee the trustworthiness of digital health. But the question, of course, is how do you do this? And that brings me to the beginning of my presentation. Is quality of data a precondition of quality of care, or is it the opposite around? For me, the answer is neither. It's not a question of the chicken or the egg. It's about taking the next steps, but at the same time, not neglecting what is already existing. The conclusion of the report, "To Err is Human," of the Institute of Medicine 20 years ago remain extremely relevant today. The question is, of course, now, what are those next steps? I think the building blocks become more and more clear. Quality of care in our digital healthcare system is guaranteed inter alia through health technology assessment, quality of data, and data governance. These quality strategies, however, do not stand alone. They have to be embedded in an already existing quality improvement framework, into existing quality aims, into existing quality dimensions. If we want to ensure patients to trust our digital health systems, we really need to combine all our strengths and see where one expertise can help the other. Quality of data is certainly a crucial part of the strengthening process, but it's not the only one. And it's not a general story. As was already concluded in the report of the European Observatory in Health System and Policies, when it comes to quality in healthcare, there's no one-size-fits-all story. And this is equally true when it comes to quality of data. We should look every time what the quality improvement is about. What do we want to achieve? Who do you want to focus on? What is the aim that we want to reach? With which partners? And how are we going to do this? And only once we know all these answers, for me, quality of data then means that we can strike the right balance. But always with one very important thing in our minds. Quality of data within quality of care means quality and trust for the patient. My conclusion brings me back to the beginning of my presentation, but with a renewed interpretation. Crossing the quality chasm today means that quality of care and the community around quality of care and quality of data and the community around quality of data, which is gathered here today, really need to work together. We need to close the gap. We need to bridge the quality chasm once again. Thank you very much for your attention.
From there or from the table, but I can get you a mic.
Professor Tom Goffin, thank you very much for your very inspiring talk. It opened a lot of eyes, I see, in the audience. I can't see the eyes, the remote eyes, but in the audience, I definitely see a lot of eyes opened. Another perspective, not only bits and bytes, not only ones and zeros, not only databases, but from a completely different aspect. I'm quite sure that we have time for one or two questions from the audience. Who will kick off? Okay. Nobody? Maybe.
Hello?
From remote, do we have a question from remote? Maybe I can ask a question. Sure. Once more, thanks for the inspiring speech, talk.
We have good comments from remote, but not questions.
No questions. Yeah.
Great
Okay.
and quite insightful.
Okay, it's a completely different approach, of course, but where do we have to go from now on, do you think?
The thing that strikes me when I was attending yesterday's sessions and also on Wednesday was that apparently one of the strives of many presentations is still to say to people quality of data is very important. I think nobody has to be convinced anymore about the fact that quality of data is important. The question really is, how will you put the concept of quality data into the bigger picture to make it work together with health technology assessment, together with governance structures? So it's really about looking how it fits in the entire story, depending on what you really want to achieve with the quality improvements. And so for me, it's really about closing this gap, really about bridging this quality chasm, bringing people together who are all dedicated to quality of care in general. And for me, everybody who's tackling the question of quality of health data also is a person who's tackling the quality of care question in some sense. So therefore, I think it's important to speak to a lot of people who are also occupied with this broader concept of quality of care and see how we can meet each other rather than to stick in our box and see how we can make the best of it in our box, but not neglecting the fact that there's more than just quality of health data and discussions about it.
Thank you. So this means we should tear down the silos, the different silos. Yeah. Okay. Thank you, Professor Govæn. Thank you. Before giving the floor to Professor Peter Rijnbeek, I want to announce, I'm very glad to announce that our president, Deepak Karla, is remotely present and he will join us in the great debate. He sent me his best welcome also. And he could not join us and because of surgery, but everything went well. And even from his hospital bed, he will take part of the discussions at 12:30. So maybe Maes, that is a good information for you too. Okay, now we can move on to the next speaker, Professor Peter Rijnbeek, an engineer from background, head of the medical informatics department from the Netherlands. And of course, he will talk about what's the value change, value proposition related to technical aspects. Please, you have the floor.
Yes, thank you very much. Yes, there are the slides. Indeed, Deepak actually asked me to give you a presentation on the return of investment on enabling large-scale analysis of observational data, and especially the return of investment in standardizing data and improving interoperability of data, also with an eye on quality of data. So I lead the Department of Medical Informatics, but also have been leading the Health Data Science group within the department, which has as aim to improve the interoperability of health data with a focus on Europe, but we do work on a global scale, and also build reproducible analytical pipelines to generate reliable evidence from real-world data. And finally, to use that standardization and analytical tool set to actually execute studies at a large scale that impact patient care. In my presentation, I will briefly talk about three initiatives that are at the core of our work. First of all, OHDSI, the Eden project, and I will also briefly talk about the Darwin EU initiative. So the questions we like to answer in our work are actually threefold. It's about clinical characterization. So you can think about incidence and prevalence of diseases or drug utilization studies. The second very important component is what we call population level effect estimation. So this is about causal assessments, safety surveillance, comparative effectiveness studies. And the third component is patient level prediction. So this is about answering the question, if you know everything about me, what would be my chance of getting some sort of outcome later on? And all the work that we do in the department is related to these three questions, and we facilitate that by standardizing data and building analytical tools. So in fact, we try to learn from the journey of the patient through life and all the individual elements that occur during that journey, and try to create a kind of learning healthcare system where we leverage the information from previous patients for the next patient. The challenge here is that we want to generate reliable evidence at a large scale. So we want to find and define methods and procedures to learn from all kinds of databases in different structures to create reliable evidence. And we want to do that in a very transparent and reproducible way. And especially scaling up across so many countries is a challenge, but we have been working hard in the last 10 years to create a return of investment on that work for many different stakeholders. And when we talk about reliable evidence, we are actually looking at a couple of desired attributes. First of all, we want to make sure that our studies are repeatable, meaning that if the same researcher repeats the same question over time, he will get the identical same results. We also want our studies to be reproducible, meaning that if a different researcher would execute the same study, they would also get the same results if they use the same data. We want it to be replicable, meaning that on similar data, we get similar results. It should be generalizable, ideally robust. So if we change settings in our analysis, the conclusions shouldn't change too much. And we want this to be calibrated and statistically consistent. Now, the challenges of doing that is that if we want to build our analytical tools and run that on data at a large scale in Europe, we have the problem that literally these tools do not match on the data because these data sets have different structures. So we have to create kind of adapters for each of our tools to work on these different data sets. The second problem is the problem of semantic interoperability, meaning that we use different types of terminology systems, which also make it very hard for us to run many studies and scale up. So we need to find a way to standardize both the structure and the semantics. So there's a lot of focus in my team on improving data interoperability, as we call it, standardized analytics, but we're also building a large data network, which I will talk about a bit more, and build a strong community around that, because one very important thing is sustainability, thinking about that even by design, that we create enough uptake of our work to make it sustainable for a very long time. So at the core of our work is the standardization of health data to a common data model, the OMOP common data model, to really break the journey from source data to reliable evidence in two different parts. And that's been driven by the OHDSI community, Observational Health Data Sciences and Informatics, but also in Europe, the European Health Data and Evidence Network project, my project, has been pushing this strongly. And how does this help? So especially if you think about things like reproducibility, by splitting up the journey into two different steps, we can make independent analysis steps after we have standardized the data to the common data model. And it makes it much easier to reproduce this study over time. The other interesting point is if we talk about replicability, if we do not standardize our data and we get similar or maybe different results across databases, the question is this really because of the data, or is it because how the analytics have been implemented by each of the individual organizations that then produce the results? And we like to disentangle that. We want to make it two separate components. And that we can do by first standardizing the data, of course, looking at the quality of the standardization, but then have the same common analytical step, so you can at least be sure that it's not because of the analytics or the implementation of a protocol that's shared with the data owner that you see these differences. And robustness, of course, is also quite easily checked because of the automation. You can parameterize your analysis and try different types of analysis on the same database fast. The driving force of our work is the Observational Health Data Science and Informatics community, OHDSI, who has been building the OMOP common data model. And I have no time to go in depth here, but feel free to reach out if you want to know more about the model itself. The community has been growing very fast in the last years. Many collaborators all over the world. And I would highly recommend to have a look at where the OHDSI community has been and where we're going edition of 2022. It's online on the ohdsi.org website. It's a very nice overview of all the work that has been done this year, which I think was quite impressive again. Also in Europe, there's a lot of activity, and from Erasmus, we are driving the European Symposium, and we had one this June, first time face-to-face again after the pandemic, which was a very nice event at the ship in Rotterdam. And it was very good to see that there were, again, a large number of new people joining, also more and more people who already have a CDM. So in this meeting, there were 107 people who had their own OMOP CDM or access to that. And we had a meeting with a lot of nice new presentations from new organizations in Europe that have moved their data to OMOP. And especially what I'm very proud of is to see that there are many national nodes being formed in Europe, meaning that, for example, in Italy, there's an institution that takes the lead and is gathering many data sources in Italy, standardizing that to OMOP and run studies within the country, but also across the country. And there were presentations from many geographic areas, even including Ukraine, which we were very proud of that they were joining. If you see the uptake, it's quite impressive to see what the community is generating. And there's a new dashboard being created, data.ohdsi.org, where you can look at all the different publications that have been generated or have been created based on the investment that we did in standardizing the data. And those are very diverse, from methodological papers onto studies. The European Health Data and Evidence Network in this ecosystem is really driving the standardization in Europe and building that federated network. And not only the informatics question is here interesting, but also the generation of the evidence. So we are also running studies across these databases. The investment made here is coming from FPA, the pharmaceutical industry and partners, and also the IMI, where in this specific project, it's quite interesting that there was an investment of 29 million to make this happen, but 17 million of that budget was reserved to help data sources standardize their data to OMO. So Erasmus was working a little bit as a bank, and based on calls, we could give data sources funding to standardize. And that was done through open calls. We had 2 calls, one call for data partners to get up to 100,000 euro funding, and another call for small to medium enterprises, companies in Europe that help us to map the data and create their own value or economic value by creating services for these data partners. And this was a very nice development, because when I wrote the proposal, we were not sure how many companies in Europe we could attract and whether the value proposition was good enough for them to participate and invest considerable amount of time of training their people. And it was great to see that at the moment we have 64 companies in Europe that we have certified and trained to help with the mapping and to also continue that after the Eden projects. And this is a great achievement, I think. And I know there's also SMEs in the room here that have created their own business and are growing because of their early investment. And the return of investment is now really that there is a network, they have good relationships with data partners, and they can continue that over time. We have trained these data sources by an e-learning environment, the Eden Academy, which has been used by a very large group of people, including also the OHDSI community, with courses also on quality of data and how to assess that, and how to assess and how to do the ETL, or the extraction, transform, and load process. For the quality control mechanisms, there's been a focus throughout the project. So quality here is all the way from looking at how the ETL was done, how the analytics are built, but also how the results are generated for certain studies and how to make sure that those are well calibrated, etc. And there's a nice report that I can recommend you to have a look at on quality assurance and control procedures that's available in our Zenodo environment, but also 2 very nice publications. One is on increasing trust and real-world evidence through evaluation of observational data quality, which describes a data quality dashboard where Maxime Moynat later in one of the parallel sessions will go a bit more in depth and explain you exactly how that works. But this is a method for us to run against the common data model and look at all kinds of different aspects of quality and provide feedback to these data sources to improve their data or their ETL. And that was assessed also in another publication where we used the data quality dashboard to improve the Eden network. And we followed a large number of data sources in their journey from source to the CDM and the use of the data quality dashboard in that process. There's also a nice opportunity here to generate, to create standardized tools to create quality reports. And one of the tools that is now being used by all data partners is called the CDM inspection R package. So you can run that against the data model and it will generate literally a Word document that has a predefined set of quality metrics and gives you insight in also the performance of the data source by running all kinds of queries and look at the vocabularies in the mapping. We also use this package now, or slightly modified version within the Darwin project. The number of data partners that jumped on the train is really large, much larger than we expected initially. Up to the last call, there were 400 data partners that wanted to be part of the ecosystem, of which we have selected 166, and they are in process of mapping their data to the common data model. But the recent call, and that's the one that was closed last Friday, there was an impressive increase of 158 additional data partners that want to join. And those come from 30 countries. And I think this really proves that there's so much interest in the standardization of the data, and that really opens up a lot of return of investment by being able to run studies at a very large scale. And there are many publications created. This is just a snapshot of some of the methodological papers that we've been working on in Eden. That is ranging from building R packages to look at treatment patterns, so first, second, and third line treatment, up to building prediction models to assess the risk of COVID-19 and hospitalization of that, and doing all kind of methodological questions around prediction. There are also many studies that we have run on the common data model that helped the European Medicines Agency informed them, or that we have been running for the EMA directly. And this is an example of one of these studies that was published just a few weeks ago, which is a collaboration, also within a framework contract that we have with the European Medicines Agency. But we can scale up, and that's really important. Running these large-scale studies becomes much easier. So if we want to look at background rates of, for example, adverse events of special interest, we can scale up to very large numbers. And this is ongoing work where we are looking at these background rates on many data sources. And this is in total almost 500 million patients in the background and 23 million patients with COVID, which allow us to run a lot of analysis and looking in age and gender groups to assess the background rates and to understand better where we look at, also when we look at the side effects of the vaccines. I want to close with just a few slides on the Darwin EU initiative, because this is another stakeholder that's benefiting from the work that we've done, and the return of investment is here not only for us, that we are actually selected as Erasmus to run the coordination center, but the main thing is that the return on investment is that we are able to provide results quicker and get that results quicker to patients. The objective of Darwin EU is to build a framework to support better decision-making throughout the life cycle of medicinal products with timely, valid, and reliable evidence from real-world healthcare. And that is done by establishing a growing network of federated data sources to execute all the steps of high-quality non-interventional studies within the network, and to make these studies then available to the EU regulatory network to support decision-making. And this is done exactly as how we have been working in Eden, in a federated network where the data stays local. We bring the tools to the data, which is possible because we standardize the data, and we return the results back to the coordination center, combine the results, and send them back to the regulator. And the coordination center is in the middle of this, with data partners, either individual data partners or data permit authorities, which are being developed also in the context of the European health data space. It's maybe nice to mention that one of the use cases that has now been initiated is one that's led by the EMA together with the coordination center to run some of these studies even beyond the Darwin network. The number of studies is large. It's a very ambitious initiative. I'm not calling it a project deliberately, because even though this is a 5-year period, of course, the idea is that it will continue. But we now are in like 2 years of establishment phase where we are setting up the coordination center, and we start to run some studies this year, but it will grow very fast up to about 140, 150 studies in year 4 and 5. To do this, we need the work, the investment that we have done in the last 10 years, because we cannot simply create an ecosystem by scaling up the number of people and creating more parallel teams. We need to be smarter. We need to standardize the data. We need to standardize the analytics. And that is, of course, only possible by standardizing to a common data model. So the implementation roadmap, as you see here, is we start with studies in year 1, setting up all the infrastructure, the tooling, the processes. It's a lot of work. And in phase 2, this will increase. And then we will slowly move into a more larger scale of studies, and larger number of studies, and also further explore the integration with the European health data space. If you want more information about Darwin, and there's much more to share, but it's not possible within this period of time, have a look also at the nice newsletters that come out. Also, the website is coming up. And if you have questions, reach out to inquiries@darwin.eu. If you want to know more about Eden or Odyssey, have a look at this information here. There's also a Zenodo page, you can look that up. And there's a nice book on Odyssey in Chinese and South Korean, but you can definitely also get the English version if that's what you prefer. Thank you very much.
Thank you for giving us insight in your club.
Yeah.
May I say club, because
Yes.
it's getting a very big club.
Growing, yeah.
Are there questions from the audience? Maybe just introduce.
Yes. Hi, Peter. Gordon Johnston from Johnson & Johnson. No relation, no relation whatsoever. I think Darwin and Eden are fantastic, programs. And, on that regard, I want to give credit to my colleague, Nigel Hughes here. I just want to touch on the conversation that Marcus and I had inside the hall and outside the hall yesterday in regards to Article 37 of the European Health Data Space and the idea of having this cycle of data cleaning or data laundering, whatever we want to use. And obviously I articulated, some of the issues that I had with that yesterday, and Marcus was very patient in listening to me. And I still hold on to those issues by and large, but and we talked yesterday about mandating behaviors or mandating certain things because, we need that to make the changes that we want to see. And I see I see that whole thing of federated networks and bringing the tools to the data, keeping the data local. And, again, I'm not I can't get my head around fixing individual data points. I'll never make that shift. But I can believe in things like the data quality dashboard in terms of giving, the local data sources that feedback on, what needs to be improved, what needs to be made better. You're still driving a data quality conversation as a cycle. You're not confusing data quality with data integrity, which, Marcus heard me kind of articulate yesterday.
Yes.
I'm a big supporter in everything that you've talked about.
Thank you. Yeah, it's indeed a good point that data quality dashboards is a dynamic thing. So that's if you talk about these cycles, that's actually how it's been used as well. So if we identify new issues, we build it into the tool and we can run it again and optimize it. So, for example, prostate cancer we should not find in women. Like there could be a check that we built in, right? They maybe come out of some study. And then we build it in a data quality dashboard, which means that check is going to be executed on all the databases that are in the process. So it's a learning quality framework that I think is very powerful. What's also quite interesting is that when we do the ETL, the data custodian is confronted with its full data set, which is not always happening because they focus on a certain study. And we see that during the ETL process, they learn a lot about their own data. They actually never knew that these issues were there. And it helps them to even fix things in the source. And I think that's another important aspect. Marcus? Yeah.
Thanks for the great presentation. Markus Kalle from the Finnish Innovation Fund. Also member of the IMA Big Data Steering Group and the Darwin Advisory Board. So I have been following your work quite closely. I think it's amazing what you do. And I think we need much more of this kind of doing in Europe. Question regarding the federated learning and this common data model. Where is the limitations in that? I mean, we talk about the promise and we see the results, but where do you see the limitation of this kind of work and what is needed that can be met by these kind of methodologies? Yeah. The second question, 50 studies a year in a couple of years' time, for me, it doesn't seem that large amount anyway. And I'm just wondering, how do you limit and how do you choose who gets to use your very valuable network? And how could we enlarge the usability of that?
Yeah,
thanks.
Thank you very much for the question. Yeah, so I think in every solution that you can think of, there are limitations, of course. And I think in the open common data model framework, one of the current challenges that we are looking into is the large amount of source vocabularies that we need to map to the standards, and there's quite some effort needed to do that. So looking also in mechanisms to make that faster is something that we need to invest in. Of course, it doesn't really jeopardize studies, because for individual studies, we can always do a very fine-tuned check on all these mappings that have been done. There is one big other topic that we are working on, that's the definition of what we call phenotypes or co-definitions across the different data sources. Because even if you standardize to a common data model, you do not solve the heterogeneity of the underlying healthcare systems, right? So you still have to find ways to maybe address that one data source simply doesn't have a code for diabetes, but only has insulin use as a proxy. So you need to define these phenotypes, as we call them, or core definitions, and look at the quality of those over time and improve them. So this is ongoing work, which I think we can handle as a community, but it's definitely something we need to do more in, I would say. Your second question about who is going to run studies in Darwin is actually not up to me to decide that. It's up to EMA to decide that. How it currently works is the questions come from PRAC and other committees. EMA forwards those questions to the Coordination Center. We look at the feasibility of these studies within the current network of data sources. And then there's a standard process of feedback and interaction with EMA to then decide, okay, we're going to run on at least 5 countries in Europe, and we're going to pick these databases for it. Of course, that continuously growing list of questions will also drive the selection of additional data partners in the upcoming years. So that's why in Darwin, 10 data partners per year are onboarded. I think looking at the description, the call description, there's definitely also an intent to have other stakeholders involved, like think about the national competent authorities, or there's also some work sessions being set up with HTA bodies. So they will also be asking questions eventually to the Darwin Coordination Center. But my understanding is that will scale up over time, and initially it's EMA itself and its committee that are the main requesters of studies, but later that may change. But it's not under my control. Maybe that's a good thing. That's not under my control. Yeah.
It's a challenge for my condition, you know.
Hi, good morning, Peter. Nadir from Sanofi, Nadir from Sanofi. Thank you for the presentations. I think it's fantastic to see that this is, now getting to the point where results and publications are being derived for that. My question is really that we are still addressing the heterogeneity of data and quality of the source after the fact. So what is being done, or what are the plans to also reconnect with the healthcare? I mean, we've heard this morning the need for connecting those two words, so that by design, the data are entered and managed to be research ready.
Yeah. Well, there's so much you can do in a lifetime, I would almost say. And so we are not controlling that. The only thing we can do within the work that we are doing currently is providing the feedback to the data custodian to take action, right? So I also have no mandate for them to fix things. But if it turns out that the data is just not at the right quality, they will not be asked questions and they will be moved out of the system. I agree with you that there's a lot to improve just at the source of any data source that we have. If we look at hospital data or GP data, definitely things to improve, especially on how we record things. Maybe too much still in unstructured text needs to be more structured. So a lot of effort that can be done there, but I don't think it's us who can really fix that problem. We can only facilitate feedback to them so they can take action themselves. It's not within our mandate to do it, unfortunately. But I fully agree with you that that is an important space to be in, and maybe also for others to put a lot of effort in.
I think, is it a time to now have these conferences also with this topic presented in scientific conferences in those therapeutic indications? Because I think we have those two words of the clinicians doing the research and the data doing the research from data, but they are not connected. And I think you have probably with all the questions that you are receiving, a good starting to grasp what are the type of data that are more and more useful for research.
Absolutely. And that's especially because of the size of the data network that we have set up, and the ability to run common analytics to look at quality, we can, for example, look at all measurements and look at their units and look at their ranges and do all kind of feedback there. So there's a lot of opportunity to do that, I agree. And integrating with the clinical communities is definitely something that's on the roadmap to do. Even if you look at the COVID-19 situation, where we had to produce results very quickly, we now saw that the GPs that we get data from were much more eager to share data with us because they understood the needs. But we're also very interested in the findings that the things we found in their data to improve their processes. And we saw over time different choices of mapping in the GP practice or just putting in free text instead of coding it. And we make clear to them, if you put it in free text, it will be harder for us to extract. Just pick the code. And that takes time, and it's not. I'm not the only one that's saying that. I think,
A very, very last remark.
Nigel Hughes from Janssen and Eden. Hi, Peter. Actually, just following on from that, there's an important dimension that's missing from here, and actually a population that's missing from this probably audience, and that's those who develop the data capture systems, electronic health record, and so on. As we've seen, Peter, looking at this vast number of applications has given us amazing insights into the sheer heterogeneity across the whole of European region, from Norway to Israel, from Portugal to Serbia. It's complete, it's almost like Wild West, and some of it's bespoke, some of it's commercial, but actually, we're focusing a lot in this conference about clinicians and healthcare providers inputting the data, but they only can do so much. In fact, there's a quite a degree of our applicants and data partners who, when we ask them, for instance, to run various tools to provide the schema of their data sets, they can't do that because they don't have the permission from the EHR vendor. So there are a few things that we need to look at critically, I think, to help improve the situation. But that also starts with the vendors and the data capture systems themselves.
And even in our own group, we see that. So we have a data source on GP data that's coming from many different systems in the Netherlands. And we really see within the country, across the different systems, differences, right? And that's just because the data entry is different in those tools and needs improvement.
Thank you, Peter. Thank you once more. I want to have a very last warm applause for both keynote speakers. Thank you very much. I'm going to close this morning session, and I really want to invite you to the other breakout sessions who will be starting within 55 seconds. Thanks very much for being here.
Thank you so much, Christophe, for this wonderful panel and guest speakers and audience. So Zoom participants, please stand by. We are going to do a technical break, 5 minutes, for allowing physical participants to move rooms, and the ones who are going to stay in this room, please bear with us for 5 minutes as we close the session now, and closing also the live stream, please. Podem cortar o live stream?